I want to talk about left main trifurcation PCI approach. I recently came across a couple of interesting cases which triggered me to give this talk. I encourage you to review my bifurcation PCI playlist, particularly review the talks on bifurcation left main PCI. When we talk about left main trifurcation, we're inherently implying that all three branches supply a large territory and are important and are large in caliber, more than 2.25 or probably more than 2.5 or so. I'm not talking about cases where we have a very diminutive small ramus or very diminutive left circumflex, in which case you just tend to ignore that third diminutive branch and focus on your main two branches, whether provisional or two-stent strategy. Few additional ideas regarding left main trifurcation. Left main trifurcation should also include all conditions where that third intermediate branch originates within 3 millimeters or 3 to 5 millimeters of the LAD or left circumflex. So it doesn't have to be an exactly a ramus branch. It could be high diagonal or a high OM within 5 millimeters of the other branch. That would qualify it as a trifurcation. Another idea is that anatomic studies have shown that when you have a left main trifurcation, the angle between the LAD and left circumflex is about 90 degrees, which will make it easy to use some stenting strategies such as perfect T or the tap strategy. Another idea is the Finet law. In bifurcation, we've explained in the past that the diameter of the main branch is equal to 2/3 of the summation of the two side branches. And the same applies to when you do kissing balloon. The diameter of the kissing balloon in the main branch is equal to 2/3 of the summation of those balloons. In trifurcation, it's somewhat close. The diameter of the left main or of the main branch is equal to 0.577 of the summation of the three diameters of the side branches. In terms of classification, you may use the Medina classification that is used for bifurcation to classify trifurcation, with 0 or 1 to each of the main and side branches depending on involvement more than 50%. You may have what we call a true trifurcation in case the main branch and all three side branches are involved, or you may have true bifurcation within a trifurcation when the main branch and two of the three major side branches are involved more than 50%, and you may have what we call single branch disease within a trifurcation when one side branch is involved along with the main branch. Two-stent strategy may be considered if you have a true trifurcation or true bifurcation within a trifurcation plus complex disease. So it's not just true trifurcation or true bifurcation within a trifurcation. You can still do single arm, one stent provisional strategy for those, but you consider a two-stent strategy if you have those plus complex disease. So it's complex true trifurcation or complex true bifurcation within a trifurcation. So it's more than 70% and it's long and it has heavy plaque and or calcium burden. Try to avoid the three stent in all scenarios in the overwhelming majority of cases. I will explain a general technical approach for left main trifurcation. There are no standardized paper on trifurcation approaches, unlike bifurcation approaches. So I will use my personal judgment in describing those approaches. So those are a general rule. Again, it's a trifurcation where all three branches are important. You may have disease only between the main branch and one of the side branches, or all three side branches may be involved. but I'll describe the general approach to all those scenarios. One, you need to triple wire. Two, you try to stent into one branch only, regardless of whether only one branch is involved or all three branches are involved. You try to just do provisional stenting into one branch, the most important or most diseased branch, typically the LAD, and you follow a provisional approach to the other two. Now, if you have complex disease in all three branches, meaning not only they are all disease more than 50%, they are disease more than 70% with complex disease. In those cases, pick the two most important one and do two-stent strategy for those two, and just protect the third branch with a wire. And be ready to sacrifice that third branch. In a sense, be ready to accept a final result with tight residual stenosis in that third branch. The third wire will prevent it from shutting down fully, but you'll have to accept the suboptimal result. And that's the approach I prefer. Just focus on the two branches, do two-stent strategy, and protect the third one with a wire. And keep in mind additional technical ideas. If you have three wires in place, in order for you to do kissing balloon, to place two balloons while you have three wires, you need a 7 French guide. Also, if you have three wires in place to do simultaneous stent balloon, meaning a stent in one branch and balloon in the other, such as when you do tap, you're doing a stent in the side branch while you're having a balloon positioned in the main branch. So tap or sequential single kiss crush or DK crush, you need at least 7 French. You can do 6 French if you have double wires and your stent balloon are less than 3.5 millimeters, but you need at least 7 French if you have a triple wires. And you need likely 8 French if your simultaneous stent and balloon are over 3 to 3.5 millimeters. Another idea with provisional approach, if plaque or carina shift occurs in the other two branches, for example, you stent left main to LAD and you're having bad plaque or carina shift in the ramus and the left circumflex, you may do sequential kissing balloons of juxtaposed branches starting with the non-stented branches, meaning you'll have to rewire the ramus and the left circumflex through the left main stent, and you do sequential kissing balloon, left circumflex ramus, then ramus LAD. Sequential kissing balloon of juxtaposed branches finishing with the branch that is stented, the left main LAD. Or better yet, you may do a triple final kissing balloon, meaning you rewire and you do a triple simultaneous kissing balloon in all three branches. You need at least 7 French for that, and it may be tight. You more likely will need 8 French to do that triple kissing balloon, the so-called trissing. Now, if 3 stents are eventually needed, and that should be an exception, again, even if you have complex disease in all 3 branches, you try to stent 2 and just protect with a wire the third. But if you choose to eventually stent that third branches, the technique we use would be sequential or double 2-stent technique. So you do bifurcation stenting for LAD ramus and bifurcation stenting for LAD left circumflex. And it is best to use sequential or double 2-stent tap technique to limit the amount of metal overlap. So you do stent the left main into the LAD, then you do tap stent into the ramus, then you do a second tap stent into the left circumflex. Or alternatively, you can do perfect T nano crush into the left circumflex, which has the same steps as the standard single kiss crush, except you're creating very little protrusion or crush into the main branch. So you do that perfect T nano crush into the circumflex, then you nano crush it with a left main LAD stent, then you do a tap into the ramus. So it's best to use that double two-stent tap technique or perfect T and tap in those cases. Avoid double DK crush or double culotte. Definitely avoid that. You will end up with 3 to 5 metal layers in overlap areas. So for example, look at this. We stented LAD left main. Then if you do DK crush into the ramus, you'll end up with 3 stent layers here. Then you do another DK crush between left main LAD and left circumflex, you'll end up with 5 metal layers here away from the carina and 4 metal layers in this area that you'll have to recross to do a final kiss or tris. So the best in this case is, again, to do double sequential two-stent tap technique to limit that amount of stent overlap and stent thrombosis and to facilitate eventual recrossing, whether during the same procedure for kissing and trissing balloon or for future potential interventions. See, when you do here double tap technique, you have only one streamlined metal layer covering the branches. Whereas here you're having 4 metal layers to 5 metal layers. Even when you're only stenting 2 branches, example, the LAD and the ramus, it is best to do tap technique to make left circumflex recrossing and ballooning if needed and stenting if needed easier. You're having only one metal layer across that third branch, the left circumflex in this case, which is easy to rewire and balloon and even tap stent if needed. Whereas if you have DK crush, you'll have to cross 3 metal layers to get into that circumflex. If DK crush or culotte is done initially for the first 2 branches, and let's take here in this picture, DK crush was done for the ramus. And if a third stent is needed, then tap must definitely be the second strategy. It helps that the angle between the LAD and the left circumflex is usually 90 degrees in those left main trifurcation. So again, the best in those trifurcation, even when you're wanting to stent only 2 branches, is to do tap to stent. And if you decide to triple stent, to do double tap. But if you've done DK crush for one of the branches and you decide to stent that third branch eventually, then definitely that third stent technique should be tap. This is an illustration from a nice circulation paper. This is how they did here a double tap after a good pot. So they stented from left main to LAD. They did a good pot that opened up those left main struts into the branches. Then they rewire those branches through the distal struts close to the carina. That relatively distal strut rewiring will reduce eventually stent protrusion and overlap in the main vessel. So after good pot and distal strut rewiring close to the carina, they were able to position sequentially 2 tap stents. Imagine, have you done DK crush here into the ramus instead of tap? Imagine DK crush will go all the way here and you'll have 3 layers of metal covering here, the circumflex. Very difficult to recross and stent the circumflex. Here a reminder from my prior talk about the tap technique. Tap, again, consists of, let's say we're stenting the left main to the LAD, then you rewire that circumflex and you just do simultaneous balloon stent with as little protrusion of that circumflex stent into the left main as possible. The perfect tap, where you end up with very little protrusion, consists of this image here. You do, after left main LAD stenting, a very good pot of the left main, which would push some of those left main struts into the circumflex, and you do distal wire recrossing, not proximal, distal wire recrossing. that good pot and distal wire recrossing will allow some of that main stent to bulge into the circumflex and will allow you to position the side branch stent with minimal protrusion into the main branch, as the upper arm away from the carina is already somewhat covered by the main branch stent. And this is an illustration of how tap, T and protrusion technique will look in a trifurcation. After you stent your left main to the LAD, you rewire into the ramus and you rewire the left circumflex, and you position your tap stent with very little protrusion in the left main at the carina level and no protrusion at all in the left main at the upper arm away from the carina. Actually, you will end up with only one stent layer covering that left circumflex ostium, and it's easy to eventually rewire the left circumflex if needed. Then you do kissing balloon to better streamline flow in both the LAD and ramus and straighten those struts covering the left circumflex. And if you need to stent that third branch to the left circumflex, the rewiring and ballooning from the distal struts close to the carina will lift some of those struts into the circumflex and will allow you to do the second tap again with little protrusion. And you'll end up with a nice streamlined one layer of strut across that left circumflex ramus area. Very little metal overlap compared to doing double DK crush or even combined DK crush and tap. Same nice streamlining of stent layers will happen if you are stenting the LAD and the left circumflex, and you'll have one stent layer across the ramus if it needs to be rewired. I will move on now to show two cases that I came across recently. This is a case shared with me by my friend Nestor Mercado. This is a dialysis patient with complex, long ostial to proximal calcified LAD disease and long calcified severe ramus disease. Along with that, there is at least moderate left main disease, particularly significant at the ostium with ventricularization. This patient eventually chose to go to bypass surgery, which is the best approach, but we did discuss how to do it percutaneously. One simple technique one may consider is to do provisional strategy with a stenting from left main to LAD and just wire protect the other branches. However, by using my bifurcation algorithm, this is a complex true bifurcation of the LAD and ramus, where both branches are more than 70% diseased, in this case actually more than 90% diseased, are long, and have heavy calcium and or plaque burden. So you should ideally do a two-stent strategy for the left main, LAD, and ramus. And accounting for the fact that this is in fact not just a bifurcation, a trifurcation, this is my approach to this case. So I would do 7 French EBU radial axis, but preferably 8 French femoral if it is possible. I would sequentially rotablate left main into LAD, then left main into the ramus, or you can do rotablation left main LAD and lithotripsy the ramus if you want to simplify things. Then after that, you will triple wire. Then I would stent the left main from the ostium into the LAD while jailing the other 2 wires. Then I will rewire the ramus and do tap stent into the ramus, followed by a final kiss while jailing the left circumflex wire, as I show here. So a stent left main to LAD, rewire and tap stent that ramus, and rewire only after doing a good pot, and try to rewire the distal struts close to the carina to provide as much lift of that main stent into the ramus. Then after the tap, you do a kissing balloon to streamline flow and provide one nice straight layer of struts across the circumflex. Then, if needed, if the left circumflex tightens to over 75%, maybe even 90%, you can rewire the circumflex and do a triple kiss, tracing, or sequential double kiss. Left circumflex ramus, then ramus LAD, but preferably triple kiss. But only do that if the left circumflex tightens over 75 to 90%. And in terms of fitting, for that tap stent with triple wiring, meaning you'll have a tap stent here while you have a balloon stationed in the LAD and you have a triple wire, you need at least 7 French for that. And the 7 French may fit if you're using 3 millimeter stent in the ramus and 3 millimeter balloon in the LAD. It will be very tight. But ideally, to do that simultaneous stent balloon for the tap while you have a triple wire, ideally you would need 8 French. It may fit in a 7 French tight with a 3 millimeter balloon stent. This is another case that was done by my colleague here at the University of Iowa, Jason Allen. So this is a patient with critical ostial LAD disease, severe ostial left circumflex disease, and high OM1 disease. Also severe left main disease with ventricularization of the guide. This is a practically trifurcation because even though this is an OM, it's arising within 3 to 5 millimeter of the LAD. So it is practically a trifurcation, where this is one branch, this is the second branch, and this is the third branch. The third branch is uninvolved. The way I would approach this is the following. I would use a 7 French guide, I would triple wire, I would balloon the LAD and the ramus, then I would stent from the ostium of the left main to the LAD while jailing those wires. Then I would rewire and do tap stent of the ramus with a jailed left circumflex wire. The same wire you initially jailed during your left main LAD stenting. Then I would do kissing balloon of the LAD ramus. If needed, you rewire the left circumflex for provisional ballooning, and if absolutely needed, you may place a third stent in a tap fashion, sequential taps. It's kind of the same approach that I would adopt in that case. However, here they chose to do something different, and I will show you. So what they did, they went for triple stenting approach up front. So first they triple wired, then they did perfect T nano crush in the ramus. And I will remind you here, perfect T nano crush has the same step as the single kiss mini crush, except for minimal to no protrusion, meaning they position that stent in the ramus while minimally protruding into the main circumflex. That's kind of the perfect T. Then they crushed whatever minimal protrusion there was or no protrusion there was using a balloon stationed in the left circumflex. So that was the first stent. And here is an explanation of the nano crush technique. Again, you deploy your stent in the ramus while a balloon is waiting in the circumflex. Then you crush that ramus stent with the balloon. Then you eventually crush it furthermore with a left circumflex stent. It's very similar to the SK crush steps. The difference is that you're crushing very little amount to no amount of stent at the ramus ostium, unlike the traditional crush where you're crushing a larger amount of stent. And after you deploy the main vessel, in this case left circumflex stent, you rewire and do a kissing balloon. So nano crush, very similar steps to SK crush, but it looks different. And in this patient, after stenting the ramus and nano crushing it, they decided to position the left circumflex stent in a perfect T nano crush fashion with the left main LAD axis. they decided to stent the left circumflex, the main left circumflex, and the LAD using a nano crush perfect T again. So they did perfect T nano crush stent positioning in the left circumflex while a balloon is stationed in the LAD. Then they crushed it. Then they stented the LAD. And that was nano crush perfect T in the left circumflex after a nano crush perfect T into that ramus. So they ended up basically with double sequential perfect T nano crush. And here you can see after stenting the left main to LAD, they rewire into the left circumflex as you would do in the perfect T nano crush, which is again similar to the SK mini crush, except for very little stent crush or protrusion. So they rewired and they did the final kissing balloon. Ideally, you would also rewire the ramus and do trissing at the end. Because you've done sequential perfect T's here with nano crush, you have very little stent overlaps and protrusions, and you should be able to rewire that ramus through really just 1 to 2 layers of stents. And this is the final result. Great result.